welcome to ECR 2021. My name is Sid Purohit. I'm the VP and Chief Architect for GE Healthcare. And I'm really honored to facilitate a panel discussion here around building digital ecosystem to break down the silos. And we have got tremendous and experienced set of panelists who have been on this journey in different regions of the world. So I have with me here Andrew Fearn, who is the Director of Digital Services at Nottingham University Hospitals, NHS Trust, and Accountable Officer at EMRED Network in United Kingdom. I also have with me Dr. Karakash, who is the Chairman of Radiological Services, Istanbul Health Directorate, and he's actually a founder of Curia. And last but not the least, we have absolute pleasure to welcome Dr. Osama Al-Hassan, who is the Vice Chair of Emirates Health Informatics Society and Head of eHealth section at Dubai Health Authority. So we welcome all the panel members and welcome to the audience for this exciting discussion. So look, today, from this session perspective, so particular purpose of this discussion, as we are thinking of healthcare ecosystems, what comes to mind is a variety of stakeholders in this ecosystem, right? Like payers, providers, academicians, researchers, pharma, medtech companies, big tech, startups, and they are all coming together to address the basic tenets that we have all known, right, for a while now, which is improved access to healthcare, reduced cost, and clearly differentiated outcomes and quality. So in short, a healthcare ecosystem is a system of systems, right, play. And in this systems of systems play, where you got these multiple ecosystems, it's a non-linear relationship between them, right? And we really want to build it in a way that there are no silos. And that's the whole intent, right? No party is ever in the center. Everyone is important and everyone has a role to play. So the intent is to deliver an integrated value, right? And there are three things that I'm looking forward from the panelists to get started as part of this discussion. So the first is, look, what are the regional and local considerations in how we address the digital ecosystem and the solution build-outs? More importantly, what is the role of digital and technology in enabling these ecosystems to build a frictionless or enable an integrated and sustainable value chain? And clearly, what is the role of various stakeholders within the ecosystem, both as curators of the ecosystem and participants? And here we are specifically speaking about the healthcare incumbents, right? Big tech, pharma, clearly the large startup ecosystem that you guys and everybody's part of, ISVs, peers, providers, etc., that we spoke about. And hopefully we'll also get a chance to discuss the role of GE Healthcare as the healthcare incumbent and its Edison platform in the curation or helping curate this particular ecosystem as we are moving forward. So with that, let me start with our first panelist, Andrew. As we think about ecosystems, I know you've done a phenomenal job within the EMRED hospital system. So what was the journey you undertook to implement digital solutions across the network, EMRED network? And what are some of the outcomes that you're seeing as part of that?
Thanks, Sid. Welcome, everyone, and thank you for the invitation. EMRAD is a consortium and network of 7 organisations, all acute care providers in the East Midlands in the UK. We deliver radiology services to a population of about 5.5 million people in that space. But as in the introduction, Sid introduced me as the Director of Digital Services at Nottingham University Hospitals. So That's one of the large acute teaching hospitals in the East Midlands. We have a turnover of about £1.1 billion. We employ about 15,000 people in that hospital. And most people will know that the National Health Service in the UK and in England in particular is a tax-based healthcare system. And there are 1.3 million people work in the National Health Service. So it's seen as a single healthcare system. However, the way in which it's made up is it's made up of 500 plus individual organisations, all statutory authorities in their own right. And they all work in similar ways and similar veins to similar targets. And for the last 75 years, we've had lots and lots of data. So we are legally obliged to provide data nationally for all healthcare purposes and have been for a significant period of time. So we have lots of numbers, but we don't really do very much with those numbers. And that was our driving force, really, to try and bring a network together to tackle some of the challenges from a radiology perspective that we were seeing. So we were seeing particular issues around recruitment and retention of staff. It's quite for a tiny little place like England, it's quite a geographically challenged community that we live in. So it's difficult to recruit radiologists and radiographers. We also found that it was difficult because of that, it was difficult to provide timely and high enough quality reporting. And we also wanted to make sure that we'd got an opportunity to exploit what was coming over the horizon with technologies such as artificial intelligence. And we've done quite a lot of work around using AI in breast screening and the like across our community to try and improve the financial viability, the quality, and the timeliness of the services that we deliver to our community. Now, we could all do that separately and individually. And in our network, there are 11 hospitals, 7 organisations, and we all work separately or have done traditionally. And when we started off on our journey, trying to get those organisations to realise that there was a mutual benefit in working across a larger footprint, a larger ecosystem was our first and biggest challenge. The technology is always relatively simple. It's getting people to use it and use it in a consistent fashion that's the challenge for us. So we spent probably 3 or 4 years persuading and working really closely with our colleagues across our community to persuade them that of the advantages and benefits of working in that collaborative fashion. And we engaged with GE to provide us with a single solution through a single technical ecosystem across that community to enable us to immediately share images for our major trauma, our cancer services, and those sorts of things in terms of the way in which multidisciplinary teams work. And we also wanted to explore the data that sits behind all of those images. So in our GE data store at the moment, we have approximately 3 petabytes of data, which is an awful lot for those who aren't technical. And we have images for the last 10 years for the 5.5 million population and every little bit of metadata that you could possibly dream of. And we sit there and we thought, right, okay, we want to deliver an operational service. We want to improve our operational service delivery and the quality and timeliness of the reporting. But we're sitting on a gold mine. And that is the reason why we really wanted to explore and exploit the opportunities from the data that we have available. So what we've managed to achieve so far is some operational consistency. So by being able to look at the data over the last 8 years as the MRAD network has grown, we've been able to look at the way in which people operate, the way in which people work, the volumes of activity that can get delivered. We've looked at introducing through the Edison ecosystem that we've introduced across the East Midlands. We are now able to, as I say, immediately see images. So across our community, if there are things like safeguarding issues with individuals turning up to hospitals, seeking care that they perhaps don't necessarily need, then that can be flagged really quickly. We can make sure that we can look after our patients operationally on the ground. But what we're starting to explore now is the use of that information and data to sort of see real clinical change in the way in which we deliver operational services. So we can now report much more quickly. We can now use reporting radiographers much more effectively than we've used in the past. We can now have discrepancy meetings much more broadly discussed across a whole community rather than just in one organisation. And we're also able to really exploit those opportunities for the future. We recognise and realise that artificial intelligence and the way in which we can use AI in the future will make a significant difference too. It will start to look at what is, in the UK at least, a really difficult challenge in recruiting and retaining staff, making sure that the professionalisation of the service continues whilst we're able to meet the increasing demand and ever increasing demand of the technologies and also of the population in terms of care that we deliver.
No, thanks, Andrew. You guys have some mind-boggling numbers in terms of data that you are leveraging as a part of this. So any quick comments on the efficacy of data between the clinical images that you talked about and then the operational side of it, and then clearly the data around patients for the last 4 or 5 years as a part of your journey? Any key takeaways that you have?
Yeah, so, sorry, so just rephrase that, please.
Yeah. So you mentioned that, look, data is critical, right? And then as you have been working with these large numbers, right, within your hospital system and the patient population that you have, and you have the imaging data, which is, let's consider it on the clinical side of the house, but then you collected operational data to make your operation smoother. So any challenges or any key takeaways?
Yeah, thank you. Forgive me for not quite understanding in the question in the first place. So as I mentioned before, we have lots and lots of data, and it's taken us probably 2 or 3 years to realise that just having the data isn't the only answer. You have to curate that data in an effective and appropriate fashion for you to be able to use it properly. You need to put some time and energy and effort into doing that to really exploit that the data that's sitting there. Over the last 12 months with the global pandemic, it's really focused our attention on the way in which we use that information and data and how it's enabled us, because we've started that curation process, and this is a lot longer journey for us to remain on. But as we remain on that journey, it's enabled us to focus some attention on those areas where we might have been able to explore previously, but we would then have had to wait for research trials to have been approved and all those sorts of things. We can use data much more effectively now, and now we've broken down those silos and broken down those barriers between what is essentially really good opportunities around trusted research environments and the use of the data from a research perspective, and also from a perspective of those startup companies who are really trying hard to break into the AI world in radiology. We can create a sandpit safely for people to be able to play in and come and explore the opportunities that they might be able to deliver clinically, whereas previously that's been very difficult. So as an example, we gave over 1 million images, breast images, to an AI company, a startup company, to develop their algorithm, and then another 1 million images to test out the validity of their algorithm. So huge volumes of data enable confidence in that product that is also important, because at the end of the day, there's a human being having their results being presented by an AI tool. We need to be able to give them the confidence that that data is adequate and appropriate.
Thanks so much. Yeah, that is very critical. So, Dr. Karkash, any quick thoughts from a regional perspective? Because I know, as Andrew has got large numbers of patients, you are also running probably a much larger set of patients as digitalization journey within Istanbul?
In Istanbul, under my jurisdiction, there are 68 hospitals and 17 million people. So we are performing almost 1% of the entire global radiological service. But the thing is not just integrate all the data. The thing is this is a paradigmatic change. The data now, the platforms are becoming more centered on patients and the populations. So for example, we have an MOH-owned system, the EPOS. So all hospitals in Turkey, the public and private, are interconnected, and there are over 30 million active users. Now this system is, of course, not radiology, it's a telehealth system actually, tracks the patients across all country for the full cycle of care, the hospitalization, outpatient visits, the primary care, and enhanced patient engagement. The health data are aggregated around the patient, as I told you, not on units or locations. But the main benefit of the system is not just to provide a holistic view of the patient, but to identify the needs and the actions in the population health issues. So such benefits were seen during the pandemic, which EPOS and its extension, the S, helped it to be contained and controlled by providing the real-time risk assessment of each resident and also geographically mapping them with the proximity warning. So I believe that such countrywide digital solutions will give us deeper insight on what is most critical to work for the population and help to understand the overall costs and the risks better.
Absolutely makes sense. And then, Dr. Karakash, in Turkey, you're partnering with GE to address needs of this digital ecosystem, right? And I understand that you leverage Edison platform from GE, which is your main platform enabler to develop AI applications. So in your mind, what are the parties in a digital ecosystem, and what roles should they play to create an efficient and unsiloed collaborative environment?
Thank you, Sid. A hard question. So, well, at the heart of the ecosystems, we know that there are now enabling IT platforms, so which the applications could be developed and run. The major players, including the big tech, med tech, are allocating huge resources in establishing such platforms. However, they do struggle and they do retreat for AI in the medical field. We see such things underscoring wider challenge that tech companies encounters. So in such cases, what I believe, there may be a lack of the involvement of the end users in the app creation process. So no matter what we do or how proficient we are in the use of apps, we all must enter into a meaningful relationship with them. So therefore, end users must be actively involved in the development and the deployment of such products, the apps. Without such involvement, necessary functions and the abilities may be missed, or the products may be overcomplicated or over-designed. So under both of these circumstances, these products may create considerable disaffection and reusability. So as always, the voice of the final customer, in this case, with someone with a broad clinical expertise in such case, is very important. So global companies, big techs, med techs, whatsoever, should first look for clinical experts who are deeply aware not only cutting-edge developments, but also the regional clinical practices, and they must incorporate these experts in the deployment and development process. Of course, not only the clinical experts, but there are many other constituents and the partners to bring industry-grade apps into reality. As I mentioned at the introduction, the first thing to do is to deploy an enabling IT platform with advanced connectivity and intelligent data analytics to interconnect all parties. Such super platform may bring services that complement each other together, enabling them to strengthen one another. So this will create a value adding. GE Healthcare, as you mentioned, has now such a super platform, the Edison. So this platform may give ecosystems significant leverage in app development and deployment. In that context, we have recently cooperated, and this is announced, with the GE Healthcare to establish a successful regional ecosystem to foster commercializable innovations. This is very important. So this model is based on the presence of an Apex R&D corporation. So it will act as a strategy maker, network integrator, and a boundary spanner. We hope that it will break down silos to create synergy and reduce costs and risks. So all these players, there are many players, funders, payers, patients, scale-ups, startups, the big techs, medtechs. So all of them will be physically integrated by Edison platform, which will allow seamless flow of the digital data within the members of the ecosystem and the value chain participants. I hope that the Edison will accelerate and simplify product development processes and the creation of the value chain. The partnership at large will open doors to develop and deploy apps to provide tangible clinical, economical, and operational outcomes. To start with, we are conducting certain POC projects on COVID, on advanced breast AI, that kind of things, and also integrated service asset and workflow management as model lines. So these projects will be finalized this year, and we are trying to test the ability and agility of the system to develop and to deploy apps. So as also I will have to give a final comment on that issue. I would like to stress the potential I see for the startups as part of the ecosystem to invest in developing applications in the healthcare. Although globalization and internet unite the world up to some extent, I believe the world is not still flat. So in that context, companies must develop and capture regional needs and demands effectively to add the value to regional services. Locally developed products to go global are also the key for the sustainability of the regional economies. So, but in that context, startups must cooperate with global players to establish successful marketable models to foster innovations. Only with such partnership, they may go to market in time, as Steve Jobs said, and conclude it by minimizing overall costs. So we are partnering with one of these global players, the GE, to accelerate and simplify the product development process and to create the value chain. I believe that by using the right foundation for collecting, analyzing, and using the torrents of data, the startups especially will be the key players in the new age where more accurate, personalized, and preventive medicine is provided to promote regional, human, and economic welfare. Thank you.
No, this is great. So I kind of latched in on one point you made, which is, I believe you called out the distinguished role of healthcare incumbents and then involvement of end users as a part of this application creation process within this ecosystem. But as we go forward, Dr. Karakash, and based on your journey, how do you reduce the friction between all these healthcare ecosystem players from a technology perspective? If you can comment on your experience, because you've been on this digitalization journey, for us to kind of understand what the lessons learned.
Especially, okay, you have to use two things. First, the organized should act as a whole. So you have to use some boundary spanners. So the boundary spanning means you have to be active in the industry and in academy and in startup, and in the government. So otherwise, there are gatekeepers. Gatekeepers keep the people away. So, for example, in the Silicon Valley, you may have a big tech company, but if there are no doctors involved in the process deployment and things, this will, okay, innovation should be marketable. When we say market, we mean customer. This is very important. In the marketing point of view, the customer defines the market. So, except in a very few cases. The second thing is very important. You have to use some physical thing. For example, why we are united? Because there is internet, the OneNet. This connects each. In this special scenario, probably a super platform. The Edison will connect each party to other, and I hope it will democratize the system. This is very important, democratize the system. So now the players are empowered, and will be valuable players in the health industry, I believe.
Yeah. No, thanks much. Dr. Osama, just following up on what Dr. Karakash spoke about, can you just comment quickly on this application innovation and application development that Dr. Karakash spoke about from your experience at Emirates?
Thank you very much. Can you hear me very well?
Yes, we can.
Okay, so I'll try to rephrase what Dr. Karakash said. This could be more of the terminology that is, I can say, more understandable in our region. So everyone knows that after COVID, like everybody knows, we learned the hard lesson that our ecosystem is not functioning well. We need to reshuffle, we need to disrupt, we need to adapt to the new normal. And I believe that now, even with I'm talking about every healthcare organization, whether small or big, government or private, they realize now that their IT is no longer sustainable. They looked into their balance sheet for the last maybe 5 years, trying to evaluate how much they spend on IT and how IT is helping them now. And they will see big gap. This big gap is that whatever millions of dirhams or dollars they spend into an ecosystem, most of these systems are silos, are not agile. They couldn't respond fast to the changes in the system. And even the business model is no longer valid. You need to come up with new business models that can really, really foster innovation. So I think in Turkey, they were very lucky because at least they have a backbone of kind of an HIE system, or even the legal framework in Turkey allow them to put all the data in one place. Even this point, we haven't reached yet. However, we started our journey in UAE, in Saudi. Now they are trying to build those HIEs. And on top of this data layer, and as we go building technology on top of it, we need to put the regulatory in the picture. So talking about, for example, radiology services now. So yes, it's easy to put store and forward mechanism so we can have tele-radiology, engaging radiologists from everywhere. But now the licensor team will come. Who licensed this doctor? How can we send their data, our images abroad? We have a data residency law that prevents us from sending data or even giving remote access. So here we have legal issues. What happens if this remote doctor or remote radiologist give us a wrong diagnosis? So who would be responsible in this case? There is a lot of ethical, legal issues around technology that we need to be solved hand in hand with building technology. And I believe, as Dr. Karakash said, we need to have sort of protocol that we can bring technology people, informatics people, and informatics, I'm talking about clinical informatics. I think this is the missing jewel in our region. We have very few, very small supply of people who have the two brains, technology and clinical together. We need to support building this kind of talents that will be really part of every innovation that we need to do. So I can give an example of these protocols that we need to put in place to facilitate this communication between regulatory, between technology and between clinical. So, for example, we can have some sort of what we call legal workshops or a platform where we can try and build new regulations that can facilitate innovation. So these kind of dialogues, this kind of free playground where we can try POCs, we call this in US, they call this sandboxing. So you bring people to develop kind of a free playground where we can try POCs and from the technology side and clinical side and see how this will impact the ecosystem. And after we do and analyze and evaluate these POCs, then we come up with new regulations and new policies that can be win-win for everyone, for all the stakeholders. I think this is the only way forward.
So, Dr. Osama, just to hone in, I think, on, and you've been doing some extraordinary work in workforce management, and Andrew also highlighted in his opening comments the challenge with the skills that he's facing, the shortage of the staff, and some of the innovative models that he has put in place. And now as I think of this ecosystem, right, which is creating innovative applications that Dr. Karakash spoke about, to me, it sounds like there is absolutely a whole new set of skills, both to manage these AI-driven, let's say, clinical decision support systems, right? If the silos are getting broken down and if data is becoming the key, both from a clinician perspective, the role of a patient in this particular ecosystem, what are the things that you see from a training perspective, workforce management? And I consider, right, everybody as a part of this ecosystem, as Dr. Karakash was alluding to. Like, how do you manage that?
So we all agree that we have an issue with the workforce, and the biggest issue is that most of these clinical dreams, I can say, clinical technical dreams, needs people with multi-skill sets, not only just one, they have one angle of things. So if you bring a pure data scientist to a hospital, he will get lost. If you bring a cybersecurity guy who's doesn't know anything about healthcare, he needs 2-3 years to understand what's happening in healthcare. So this is the challenge. We need now to build this kind of multidisciplinary kind of workforce. And I believe the only fast way to do this is through shadowing. We need to bring kind of people who are really expert and even good in transferring knowledge. So I can spend even hundreds of thousands on one guy like that, a data scientist who has a clinical background, and he worked in a kind of academic center in the US for 5-10 years. If I bring this guy for 12 months only to my organization and make sure that he spends 50% of his time teaching our young talents, this kind is these things will become like more of craft. It's not like science anymore. So this kind of approach of shadowing, this is very important. Even you need to invest a lot on even sending your people outside to have these kind of 6-month or 3 months training on those academic centers. I've also already experienced this even in DHA, when we bring high-tech solutions like Epic, for example. Epic is, there's nobody can challenge that Epic is the first EMR in US or even in the world. But having people who really understand the capabilities of Epic, and they've developed kind of those complex workflows in Epic, it's not easy to get. And even those people, even if you pay them so much money, they still can make more in the US and they will never come. This is another challenge that we need to look at. So sending our people to learn from those experts, because they will never come here.
Yeah.
It's another way of doing things.
Yeah. Well, one last follow-up before I move to Andrew. And then maybe, Andrew, you can tail off on that one as well. So in this ecosystem now, so we talk about the healthcare incumbents and things like that. And then we talk about the high-tech EHR vendors. what is their role? Do they play a role in the clinical space or just in the operational space? Because you know the workflows rotate around EHR system sometimes from non-clinical perspective because the billing happens there. And I don't know how it is for Emirates or Dubai, but do you like what role do you see?
I mean, for the EHR, so this is not their role. This is our role to push them, to move them from their comfort zone by challenging them, by doing benchmarking. So it could be easy. If I have a health information system and I feel that I'm happy with it, why don't we benchmark with what's with counterparts in US and UK and see whether we are doing a great job or not? And then we can take this result and challenge our HIS vendor and say, I've seen it somewhere else. They're doing much better job than us. Why? So we need to push them harder.
Got it. Andrew, any follow-up comments before I move to?
Yeah, I think that's a fantastic point, really, isn't it? I mean, COVID has split us up in many ways, but actually brought us together and enabled us to work much more effectively through tools as we are doing today, to really learn from each other and learn from each other's experiences. And for me, I think the data needs to sit in a vendor-neutral space. And the providers of the technology, the applications, is a separate thing. We need to own our own data. And for me, it feels like in the last 12 months, we've probably opened the door. We've been given a key for us to really change the way in which we deliver healthcare services in the future. We've got to grab hold of that key and we've got to exploit it to our full potential. But do that together. I think I would love to learn more about some of the challenges that we've all
Andrew,
done.
I want to to have 1 minute from your time talking about the NHS Digital Academy and how it impacted the system in the UK. So this could be a way of something that we can learn from.
And I think those opportunities, we've got to get into that sharing, haven't we, really? Because as you say, we all face the same issues and challenges. They might be slightly differently, and there might be slightly different drivers sitting behind them. But the reality of it is we all want to improve the quality of care that we deliver to the people that we serve. And we all want to make sure that the staff that are delivering that care have got the best tools available to them. And we've got to excite those people, interest those people, and make sure that we can deliver in the long term what they want to see, which is better healthcare.
Absolutely. So Andrew, and I think you raise a fantastic point. So just from that perspective, I'm going to touch on COVID a little bit here as well. So in the past few years, right, we have been systematically moving from encounter-centric or episodic care to the whole school of thought around patient-centric medicine.
Yeah.
But with this event, right, other than the virtual and the telehealth aspects that we'll get into, in your mind, has it systematically impacted how we are thinking about this patient-centric care, the role of populations or things like that? Or going forward, and anything from an NHS perspective that you're seeing, which is not going to turn back?
I think we're at the cutting edge of that now. So, I mean, Dr. Karakash mentioned this in Turkey, and the opportunities that there are from having that huge population opportunity to look at population health management much more effectively, to make that really work and bring data items together. You've got to have that ecosystem in place to make sure that's effective. We are scratching the surface, just doing radiological data. What I'm experiencing now is I really need to bring all the data items into that bucket to enable me to really exploit the opportunities that we've got. So if I've got pathology data, I've got demographic history and all of those sorts of things in that same place. The opportunities for me to look at that data in a different way, to start to predict where we need to design services in the future, where we need to recruit and train people in the future to deliver those new services that perhaps aren't prevalent today. where we perhaps need to stop delivering some of the services that we are delivering and change the environment that we're offering services to the populations we serve. I think that's going to come to the fore over the next few years.
Yeah, thanks. So I see that there are a few questions in the chat. So let me ask Dr. Karakash. So I think one of the questions here is, it says, look, for institutions that are looking to implement AI apps in midterm, right? What do we need in the short run to be ready, right? And I think he mentioned, or he or she mentions around workflow, data management, partnerships, etc., specifically around AI apps. And I'll tie that to a second question similar that we have, which says for the startup AI apps, any guidance on which care areas that we need to focus on, right? So I'm going to combine both of them together. And Dr. Karakash, you can take that, and Dr. Osama or Andrew, you can chime in.
Okay, I see the question.
Yeah.
Well, okay. First of all, I might warn that now there's an AI boom. Let's make it not blow up like a .com. It's very important. Now, first of all, as gentleman stated very finally, data and information are two different things, or knowledge. First, your data should be pure, clean, and ready to transfer into the information phase, data to information conversion. This is a quite hard job to treat the data before being even recorded. So, because we have petabytes, zettabytes of data, how are you gonna reach it? So your data should be a good data, clean, pure data. This is very important. So first, the people has to have an infrastructure to acquire and to manage that data. The second question, what we gonna do with that data? So, I mean, you don't just jump to the field and say, okay, let's do AI, What do you need? So you have to do a wing-to-wing assessment first, You have to know your needs. You have to point your needs. And of course, you have to add, as Dr. San said, you have to have people who knows what to do with that data. You cannot do everything with that data. Because I'm a neuroscientist. The techniques has capabilities. Let's don't expect much. But there are many, many things. Operational things, how to break down the barrier, how to do the things more efficiently, more effectively. And you may do, for example, diagnostic tasks. For example, like pathology, there's a huge vast area in the pathology, lots of data. I mean, pathologists got at the microscope, like that, where is it? There are many, many things, but, first, again, just to conclude, first, the purity of the data, recording of the data, treating data, and, start with not a very complex task. I recommend them to start with a model line projects, first, then to deploy other things.
Makes sense. And as you speak about data and a well-curated data set, and I think Andrew also touched on it, right? Dr. Osama touched on it. Do you see role of APIs in this? Or are you guys dealing with that type of technology play across this ecosystem to reduce the friction?
We do. What?
I think.
Please go.
Yes, maybe I can add one point. So now, especially during COVID, there will be a lot of challenges with regard to developing new systems. We don't have budgets for that. So now there is a new trend to use APIs to develop some sort of user experience subsystems that can really talk to our, can say, legacy system. So rather than replacing our legacy system, we try to have a new layer that is built on data. So we have a new data layer that cross-cuts all our systems. And then we have a new application layer on top of it to build some sort of fast, quick, and functionality that really can be consumed by our customers. This kind of trend is more cost-effective, more fast, but it needs us to really own our systems. And this is the challenge.
Yeah. There is another interesting question I'll throw to the panel. With an explosion of apps in the market, with overlapping functionality, obviously, right? Everybody in the ecosystem may attack the same areas. How best do we evaluate their legitimacy and effectiveness? And how do you pick the right ones?
The commercialization is the legitimacy. There are innovations. Many of them are in the garbage right now. There were very good innovations, but they couldn't be commercialized. So the first, you have to go to the market. For example, we are talking on Zoom. There wasn't any Zoom kind of thing. There were many things like that, but there were no need, global need. Now there's a need. So you have to find that kind of products. There are gaps. You have to first find the gaps, but at the end, we'll see if it's not legitimate or not. If they gain money out of it, they're legitimate, by virtue of the management. Of course, they have to serve to the human welfare, the economic sustainability, and many things.
Yeah. And I think I'll just take a follow-up question on that, right? And again, anybody from the panel. So the follow-up around this is, it says that, do you see this as a new revenue source for traditional hospitals? So when you talk about commercialization of these apps and things like that, and I think it gets into a little bit more controversial topic that you can also touch, which says that, look, selling anonymized patient data to developers or commercializing apps in-house. So I think it's a two-part question. So first is, as you build applications, right, is there a commercialization model, which is a revenue source, right, for the existing healthcare peers, providers, or whoever is making it in the ecosystem? And then I think the second part of the question also is specifically around data, that if these hospitals or large partners within this are collecting data, is there a monetization model of that data? And anonymization, or anonymized, of course, right? Not
So Sid, we did explore that opportunity, and about 2 years ago, we started off with we've got all of this data, it must be worth something. And the reality of it is, unless that data is curated into information, unless that data is able to be brought together with other data items, then I think it's almost impossible. I think it's almost unethical for us to commercialize the access to the data. What's also interesting for us, in the last 2 years, we've been working with an AI company to synthesize data. And I think what we'll see is that the creation of synthetic data for use of building algorithms for AI companies is going to become much more prevalent. The actual data is not going to be necessary and will have very little value in a very short period of time, because synthesizing data to create an algorithm and test its efficacy is going to be to the fore. And I think for me, in terms of, if I was an AI company, a startup company now wanting to look at this market, I would build and build quickly. I would persuade somebody to sandpit or a sandbox that application and provide evidence that it works. I think professionally, our professional bodies need to catch up with the pace at which we are working. So, for example, Dr. Osama mentioned the legal requirements around where data can move and all of those sorts of things, how we can use data. For us, is an AI tool a medical device? Does it have to go through the same rigor and challenge that a medical device has to go through in most global markets, or can it just be used and can it just be exploited? And the answer, there's a really tricky path here to strike. But for me, if I was in an AI company, go and persuade somebody like any one of the three of us, we'll open our arms up to you and go, come and play, because we want to try and see if we can make an advantage and an opportunity for this. I think we also, just finally, I think we also have to see them as disposable products. They are not products that will last for very long, because the whole concept of a product that allows learning in it is not an effective solution for us to deploy at this moment in time, because of you have to put a line in the sand and go, this is the algorithm that I'm going to apply to these patients in this scenario. So the continuous learning of an application means that actually the AI algorithm will change over a period of time. So it's a very small window of opportunity for those AI companies to jump in, test it, run it, and then change again. So they have to be incredibly fleet of foot and work with those innovators across the world. Because I will buy something that's been tested in Turkey. I will buy something that's been tested in Dubai. That's the thing that you've got to, I think, break into as we move forward. Move at pace, because we've seen in the last 12 months, we're able to move at pace much faster than we would ever have dreamt we were able to do.
Yeah, no, thanks much. So, and any comments on that before we get to the final comments?
One comment, as Andrew said, it's almost impossible in many countries to make money out of that data. But if you have a very liberal economy, what they say, if the product is free, you are the product. So because in England and in Turkey there is a tax-paid coverage, the government thinks to anonymize and to use of the data, but still it's very hard. And remember, I mentioned something, a boundary spanner things. For example, we have found a body in the health within the health sciences university, Technopolis, so that the structure, the corp, has the data and shares with the academics, with the startups within that cyber parks, and with the government. So when I said boundary spanner, this is the boundary spanning. But it's in Turkey, for example, it's impossible, but it's legally forbidden to put the data into the cloud and send it to the United States or whatsoever. So you cannot send it across borders, for example. Still, it's a problem.
All right. Yeah. So we are coming up on time. We got about 5 minutes, let's say. So let me. There are a few more questions that I'll go through. So I think one of them is, it says, look, do you see that many of these layering of applications, right, from this ecosystem perspective and data sharing problems, can be solved by using integration engines? And I know it gets a little bit into technology, so I'll let Dr. Osama take the lead.
Okay. Well, I think integration engine will solve maybe less than 10% of the problem. I believe that as regulators, we need to take the Apple approach by having some sort of a marketplace, and every application to be authenticated or certified, it should come into certain go through sandboxing, make sure that they have minimum requirements, making sure that they seamlessly connect with our system, like for example, eClaim system, patient identification, whatever. So this will help them to have some sort of a smooth integration with all ecosystems, all the systems in the ecosystem, and it will give us a chance to monitor them as well. and make sure that they have what we call kind of a convincing business model. So
Yeah.
I believe that we should take it, as I said, as kind of an Apple approach. Develop a full marketplace and enforce all those apps to be part of it.
Let me take a last question, and I think, Andrew, you touched upon this as well. So the question is, it says, look, how best do we strike a balance between legal privacy regulations versus giving institutions the autonomy to be innovative and move quickly in building these ecosystems, right? So, right, I think the question is probably around, right, how do I avoid hampering the progress of these digital ecosystems, right, with the traditional regulations, is how I read it. But I'll leave it up to the panel or Andrew to start.
So if I'll start, if you like. I think that we've all changed our perceptions of how our information and data is going to be used over the last 12 months. You know, the idea of national track and trace solutions that using our mobile phone technology can tell us where we've been in contact with someone else who might have tested positive for COVID. Those sorts of things are now the norm. And I think there is a balance for us to strike here, but it is possible with volumes of data. You have to have data at scale. And this is where you're turning into synthetic data, in essence, will enable you to create algorithms that are relevant and appropriate without it necessarily being identifiable data. I think that there's an expectation from the population that I serve that we will be using technology in a way that's very different now than we did 5 years ago. And we will still have those who wish to opt out of being involved in that process. We have a process in the UK for people to opt out of their data being shared for other purposes, but the majority, particularly around health, want their data sharing to improve the health of others. And I think we should exploit that.
So, all right. So I think, this is phenomenal. So I think some of the key takeaways that I had was the thought around, look, while ecosystems are primarily patient-centric, right, the impact of population health that Andrew, you and Dr. Karakash spoke about, right? So what is that? What is the role of incumbent healthcare companies to act as curators of this ecosystem? And then how do they leverage big tech as innovative partners to move the agenda forward? Then I think from Dr. Osama, right, we talked about the impact of proposed regulatory changes, right? And specifically around data that you touched upon as well, Andrew. But what I'm also hearing, right, probably for the past 10 minutes, the bulk of this discussion is this curated data sets, right, that everybody honed in on, and the role of data in fueling the AI applications, right, and becoming kind of a liquid currency between the entire ecosystem, right, which is the purity of data that Dr. Karakash spoke about, right, some of the monetization aspects that you touched upon, and I think the regulatory aspects. So from your perspective, look, is there one takeaway that you can let this audience, based on your so many years of experience, on how to go about doing this ecosystem? So I'll start with Dr. Osama to begin with. We'll do reverse this time.
Well, I think the best way to move forward is, and this should come from the both direction, I mean, government or hospital on one side, plus the specialized healthcare companies on the other side. They need to come up to new terms and new agreements when they do projects. They need to make sure that they will bring the best quality of people into these projects, making sure that knowledge transfer will be a building block within every contract. So every implementation should end up by the client owning the system. Owning the system, maybe that means that our staff will be able to leverage the system, to maintain the system, to innovate within the system. This is the only way to get the value for money of those projects and to secure adaptability and agility for the long run.
Dr. Karakash? one takeaway for the audience from your perspective.
What? Okay. Okay. For everyone, especially the AI startups, they should have an innovative idea. They should put their idea into market in time. And in order to succeed, they have to be part of the sustainable ecosystems that would let them decrease the costs and the risks. So then they could really be valuable part of the healthcare industry, I believe.
Thanks. And Dr. Andrew? Oh, sorry, Andrew.
So for me, there are times when those people who are saying it can't be done are interrupted by those who've just done it. Spend your time and energy and effort working with people who are equally as energetic and positive and enthusiastic about the way forward, rather than bashing your head against the wall of those who are saying it can't be done, because there are enough people out there in this world who really want to make a difference, and working with people with enthusiasm and excitement for the things that they will do, you will deliver it. You will deliver it. You will succeed in doing that. There are 3 examples here of 3 different, very, very different economies across the world who, from the GE platform, have really enabled some of those changes to happen in very different circumstances. But I think it's exciting. Work with people who are nice. It always helps.
Wow, what an upbeat note, Andrew. So with that note, I really appreciate all your time and phenomenal insights. And I hope our audience really got to understand some of the journey and experiences. So thanks much again. Thanks, audience. It is really a pleasure to have all these panelists on the board. And look, if there is any questions that you have for us, for any of these panelists, right, let's keep the conversations going. Thanks much.